Good morning, YouTube. Good morning, Instagram. Good morning, Peachy on Ice Daily Show. I am coming to you live from Durango, Colorado this morning in my truck, so excuse background. But we are here to talk about, first of all, my name is Dr. Ellison Melrose. I am lead faculty with the Dry Needling Division of ICE. I am coming to you today to talk about dry needling in the pelvic health space, particularly for sexual dysfunction in females or in women. And I wanted to highlight two common diagnoses we have, which is vulvodynia and vaginismus. So let's dive right into that. First, I want to highlight in 2018, there was a joint report done by both the International Urogynecology Association and International Continence Society that overviewed sexual function and dysfunction. They did a deep dive into things like the proper screening, what proper history or physical subjective objective exam would look like. And then they had a huge section on the prevalence of pelvic floor dysfunction in folks that had sexual dysfunction as well. So that's what I wanted to highlight today. We, in the pelvic floor practice or pelvic floor space, we see it often where pelvic floor dysfunction and sexual dysfunction is highly linked and correlated. And what this report highlighted is that there's actually 37 different diagnoses of sexual dysfunction that can be attributed to some form of pelvic floor dysfunction. And that's a lot, right? So they're granted, I mean, if you look at all of the nitty-gritty diagnoses, we may be thinking maybe we're over medicalizing this patient population a little bit with specific diagnoses. But it highlights the fact that there's so many people out there that have pelvic floor dysfunction that is contributing to a form of sexual dysfunction. 45% of women that have urinary incontinence will complain of sexual dysfunction at some point in their life. Of that 45%, 34% of that is hyposexual desire disorder, and 44% of those are a brand of sexual pain disorder, which is either dyspareunia or a non-coital, so a genital pain that's not associated with intimacy. And that's what I wanted to highlight. Two most common diagnoses that we see in the clinic that can be challenging for us as pelvic floor PTs often are both vulvodynia and vaginismus. And we'll kind of get into potentially why these can be challenging diagnoses for us. But for vulvodynia, the clinical definition of this is anyone that has had pain in or around the vulvar region for at least 3 months without a clear etiology of symptoms. So they've had negative cultures, so they don't have either fungal or bacterial infection going on here. And so there's this idiopathic pain presentation in the vulvar region. And then vaginismus is a recurrent or a persistent muscle spasm of the pelvic floor, which inhibits any form or enables penetration. And there's different forms of vaginismus and different diagnosis underneath that umbrella of vaginismus. And we can kind of dive into that when we talk about vaginismus specifically. I wanted to highlight these two diagnoses particularly because without a proper diagnosis, oftentimes the internal assessment can either be very challenging or it can be very non-therapeutic and actually traumatizing to some of these folks. So if we don't have, a particular subjective exam that allows us to understand the what is going on with our patients, the whole pelvic floor assessment may be not therapeutic. So for both of these diagnoses, everything starts in the subjective exam. Let's start with vulvodynia. So vulvodynia, oftentimes folks may have symptoms similar to that of a yeast infection or a UTI that then kind of snowballs from there. They may have actually had recurrent yeast infections or UTIs in the past, and are familiar with those symptoms, and so they do their normal treatment with that, which a lot of times is either over-the-counter medication, or they might phone up their OBGYN and say, well, let's get some of these either antifungals or antibiotics on board ahead of time while we wait for the culture. Well, culture comes back negative and the symptoms are still persisting. Sometimes they may get taken away with some of the medication a little bit, but the symptoms overall typically will persist past that. And for folks that have this at this point, it is no longer a bacterial or yeast causing these symptoms. There is a brand of neuropathic pain going on. So a lot of times they have either had this for quite a long time, at least 3 months. They've seen other providers that have either provided a medical treatment or something that has been ineffective. And so symptoms have continued. And when we think about neuropathic pain and the chronicity and the persistent pain or the chronic pain side of things here, this actually heightens symptoms typically. Other subjective things that you might see in these folks is that they may have some sensitivity to light touch in the vulvar region, right? So wearing specific type of clothing may be uncomfortable, or they may have other brands of nerve-related symptoms like itching or burning, which oftentimes are two symptoms that we think about for either a yeast infection or UTI, and so that's why they get mismanaged in their medical treatment. So it all starts in the subjective exam. And while an internal assessment in these folks isn't out of the question, it can definitely be helpful. It doesn't always, it's not the most efficient way to go about treating this pain presentation. When we think about neuropathic pain, we need to think about, okay, why is this nerve so irritated? And a lot of times in vulvodynia, they see that there is either a irritation of the nerve. Sometimes there can even be, some changes in the myelin sheath of these nerves. So there's actual nerve damage associated with it, depending on maybe what the original cause of the uh, nerve irritation was. And so when we dive into, we've highlighted their subjective complaints, we know what's going on here. Where do we go from there? The internal assessment may be valuable in order to see, is this maybe a hypertonicity issue? So if we have tight pelvic floor musculature, can we teach them to relax their pelvic floor and allow for improved blood flow to the pudendal nerve that could be contributing to some of these symptoms? So there is value in that, and I believe that there is oftentimes in the pelvic health space, we are so used to trying to treat the patient's symptoms ourselves, whereas we can teach our patients to help themselves with learning how to relax their pelvic floor. So there is a benefit in the vulvodynia patient population to utilize the internal assessment. But when we think about efficiency, so how can we treat a neuropathic pain presentation the most efficiently in our clinical setting? I am in the dry needling space, and so we use dry needling a ton outside of the pelvic floor world for treating various different brands of pain, one of which is neuropathic pain. So dry needling can be a super efficient tool to to talk to the nervous system and do a nervous system reset to the nerve in question, which oftentimes is the pudendal nerve. So dry needling is a very efficient tool in order to improve those neuropathic symptoms. With that being said, everything we do physically, manually, we need to highlight that this is a persistent pain diagnosis at this point. And so we need to be utilizing our pain neuroscience education, educating these folks about what happens to our nervous system when we have had pain for a long period of time, and that pain doesn't necessarily equal damage at this point, or else everything that we do with our manual skills or dry needling will only get us so far, right? So vulvodynia, again, a lot of times these patients come into us with chronic symptoms. So they've been going at this for a very long time. They've had typically a medical mismanagement, or they've been having some medications on board that weren't helping their symptoms. They have a lot of sensitized nervous system. And so we want to make sure that we are using the most clinical efficient tool to treat these symptoms. Oftentimes as well, you might actually get some reproduction of symptoms with dry needling when we are approximating the pudendal nerve or getting close to that pudendal nerve, which can be helpful in almost diagnosing, right? So using our tools to help with localizing their symptoms. So that is how we would use dry needling in a case for vulvodynia, and in a patient population where we would still likely be able to utilize the internal assessment. Now let's pivot to vaginismus. Let's talk a little bit more about different diagnoses under the umbrella of vaginismus, and then how we would and why we would use dry needling in this patient population. So vaginismus, there's two different diagnoses, and underneath that we have two other subdivisions. So we have both primary and secondary vaginismus. So again, a reminder, vaginismus is either a persistent muscle spasm of the pelvic floor. It's either persistent or it's associated with something, and we'll get into that. So primary means that this has been forever. So this has always been an issue. Sometimes there may be a congenital malformation of the genital tract on board with this patient population as well. And if that is the case, even things like typically their first um, like uh, association with any form of penetration is oftentimes when they get their menstrual cycle. So having a tampon, and they're unable to actually insert a tampon into their vagina. From there, then they often, with this congenital malformation, or having it be a primary diagnosis, is they often are treated fairly medicalized in that state, and they may require some form of surgical procedure to widen the vaginal canal. So that's primary vaginismus. Secondary vaginismus is acquired. So it wasn't always an issue, but it could be acquired from a form of trauma. So either an emotional or a physical trauma that then caused muscles in the pelvic floor to spasm. And this can be either global. So what I mean by global is that it's every time anything enters the vaginal canal, there is muscle spasm associated with that. Or it's situational, meaning that things like inserting a tampon may be possible, but physical intimacy with or sexual intimacy is not possible. So there's no penetration available during sexual intimacy. So those are the different kind of clinical or diagnosis that we find under the umbrella of vaginismus. Oftentimes in pelvic floor PT, we will see a lot more probably of the secondary vaginismus, in that they've never had it, they hadn't always had issues, but then something caused or something triggered an issue, which causes the pelvic floor muscles to spasm, right? And that could be a traumatic birth, a vaginal delivery. It could be a sexual trauma, so a sexual assault or something of the sort. It could be a traumatic pelvic exam by their OBGYN, which I see a ton in the clinic. And so it could be an actual physical trauma with that. And then it could also be heightened with an emotional trauma as well. So a lot of times, I mean, this is a very intimate part of our body. And so there's a lot of times a very pertinent or very prevalent emotional impact to these symptoms as well. With vaginismus, 70%, I would say probably about 70% of your initial evaluation is going to be a subjective exam. Understanding the why behind these patient symptoms is crucial to dictate the course of your treatment or even the course of your assessment in that initial evaluation, right? Like, are we going to be doing an internal assessment on these folks? And a lot of times, probably not, right? So what does day one look like, or our initial evaluation look like with folks that have vaginismus? And what does our course of treatment look like for them? So typically, education goes a long way with folks that have had either a physical or an emotional trauma that has caused muscle spasms here, right? So teaching folks about the anatomy of the pelvic floor musculature, why they feel like there's a brick wall when they try to insert a tampon, right? What a Kegel is, right? So anytime people have any association with the pelvic floor, they are often just think, oh, I should be doing Kegels, right? And teaching them what a Kegel or what a pelvic floor muscle contraction is, and educating like the benefits of relaxing the pelvic floor. And this is just all done through education. So no even physical touch or assessment has been done at this point, but just educating folks around the anatomy of the pelvic floor. Anatomy and physiology of the pelvic floor can go a long way here. We also want to educate about vaginismus itself. So vaginismus is another brand of chronic pain, right? So these folks have typically had pain for an extended period of time. There's not a diagnostic criteria for duration of symptoms like there is for vulvodynia. But there is a pain cycle on board here, right? So it all starts in the brain. So it either the brain perceives an emotional trauma due to either a physical trauma or purely emotional that registers discomfort or fear associated with penetration, either from a previous exam with a speculum, from a previous sexual encounter, from a traumatic birth, right? So the brain remembers those things, which is then going to be causes muscle guarding. So pelvic floor guards, the tight muscles in the pelvic floor cause the penetration to be painful or impossible at sometimes. And then this difficulty and pain reinforces that alarm, the amygdala alarm that's going on up in the brain, right? That reinforces the that this is a threat, right? The nervous system then remembers this pain, and so every time our brain is their brain is thinking about, either having to go to the OBGYN or having a sexual encounter, anything like that, it is going to remember that, and we are going to get the same physical symptoms as the tight muscles, which is often going to lead to, decreased blood flow to the nervous system, which is going to cause potentially, perceived as pain by these folks. And so they're going to avoid those, uh, avoid whatever is causing this pain cycle, right, in those folks, which ultimately, especially if this is a sexual nature, is going to reduce the desire to, either have sexual intimacy with their partner, or and it's going to reduce that overall desire, which is then going to, again, any thought of that intimacy is going to be threatening. So discussing that pain cycle with these patients can be very therapeutic and helpful, in that this isn't their fault, So the nervous system, I like to say, it's smart but dumb, right? It remembers things, and not always for the right reasons. And so education about anatomy, physiology, about the vaginismus pain cycle, can take up a majority of your initial assessment with these folks. I also like to do, again, a guided pelvic floor relaxation series with my folks, even if we're not doing an internal assessment. So on day one, these folks, we may not be getting into an internal assessment. We may never get into an internal assessment. But we do want to teach them how to feel their pelvic floor muscles, and learn how to relax them. So sometimes I will educate them on how to do some self biofeedback, either tactile cueing, just medial to their ischial tuberosities, sitting on a yoga ball or something like that, where we have some tactile cueing to the perineal region, or the pelvic floor area, and teaching them about, again, the anatomy, and that when we're breathing, we're trying to make some of these muscles move. Increasing movement in these tissues is going to increase blood flow to the tissues, which is going to reduce you know uh, irritation to the nervous system. So teaching them how to relax their pelvic floor without even doing any physical touch yourself can also be helpful. um, this is a patient population where, after we kind of break down and help them understand the why, I like to highlight other tools we have in our toolbox as physical therapists, right? A lot of times when these folks come to pelvic floor PT, they've done their research, so they know often that pelvic floor PT equals an internal assessment, which they've had done by their OBGYN, and it's maybe been traumatic in the past, or they know any form of penetration is traumatic. And so right out the gate, I'll say, you know what, that is a tool we have in our toolbox. The internal assessment's a tool. It is gold standard for assessing how the pelvic floor muscles function, but is not everything that we do here at pelvic floor PT. And I introduced dry needling. And I know that seems like, for folks that don't have vaginismus, or don't have trauma associated with penetration, they're like, isn't dry needling more of a threat than an internal assessment? And for folks that have vaginismus, oftentimes it's not, right? So dry needling the pelvic floor muscles can be an amazing tool, as we don't necessarily need to do an internal assessment on these folks. We know there's likely not going to be anything therapeutic initially with that initial internal assessment. So if we can utilize dry needling in the earlier stages of our pelvic floor PT with these folks, it can be an amazing tool to talk to the nervous system, put a break in that pain cycle associated with the muscle spasms or the tight pelvic floor musculature. It's a beautiful kind of, what I like to say, control alt delete to the nervous system. And so it can really help with retraining that cycle of, these muscles have more control other than just muscle spasm, right? And so if we can take some of the heightened neuropath, or the heightened symptoms, down with a tool like dry needling, it may allow us to either ourselves or them do a form of uh, stretching or manual therapy, where they can improve the tissue's mobility as well, right? So, I could probably talk about this stuff all day. I've already been on here for almost 25 minutes, so I'm gonna stop it here. But I want to kind of summarize everything we talked about today. So, we kind of went into a recent report done in 2018 that dove into some pelvic floor dysfunction in sexual function and sexual dysfunction, and we dove into two specific diagnoses today. We looked at vulvodynia and vaginismus clinically, and how we can utilize things like dry needling for either treatment or even diving into a little bit of some diagnostic d with dry needling as well. And so, while we're, dry needling the pelvic floor is a fairly unique, skill. There's a lot we can do with dry needling outside of the pelvic floor as well for these folks. And so, for those that are in this space, I highly recommend taking our lower body dry needling course if you haven't already. We go into needling for the lumbar spine, the glutes, muscles that surround the sciatic nerve, and so again, taking those principles and utilizing them in the pelvic floor space can be really helpful as well. So we have some courses upcoming this fall. We have, let me pull it up right here. Um, we have a lower body course, I believe, in Scottsdale, Arizona, in the beginning of September. For those that have taken lower body or upper body, we have 2 advanced courses coming to you this August. So we have our dry needling summit up in Seattle in the second weekend in August, and then we have one down in Longmont, Colorado at the second to last weekend in August, right before Labor Day. We have a ton of lower body courses coming to you this fall, so hop on to ptonnice.com and check out what courses we have coming to you. If you guys don't see something in your area, feel free to reach out to us, and we can look at getting something booked near you as well. Well, hopefully you guys have a great rest of your Tuesday and enjoy the holiday this week. Bye.